So are we gonna include this part or? No, Liz will. I want to. I should make sure my things are not on mute.
Was it dramatic? There's might be the biggest cookie ever.
It wasn't super dramatic.
Yeah, Lark Von is good. I have to put on there. Should be good. Sorry? No, it says pretty. Why isn't it starting? Three eight seven.
387, 378.
1 sec. 378 643.
643.
What the?
And you.
Can you do a sound check and just? Okay. Hello. Can you hear me?
Here's a slide. What kind is that?
They gone?
Just pause it.
Share screen. Share.
All right, everyone, we're going to get started. We're going to get started now. My name's Sarah Ikowitz. I'm an addiction medicine physician here at St. Paul's. And welcome to the What's New in Addiction Medicine lecture series. I want to introduce our speaker today, Dr. Danny Lee. Danny is an addiction medicine fellow with the BC Centre on Substance Use and a fourth-year psychiatry resident here at the University of British Columbia. Prior to medical school, Danny earned a bachelor's degree in pharmaceutical sciences and worked as a float pharmacist throughout urban and rural centers in British Columbia. He's presenting on a really interesting and timely topic today, long-acting medications for substance use disorder. So without further ado, please join me in welcoming Dr. Danny Lee.
Yeah, thank you so much for that introduction. And thanks to all of you for coming and spending the lunch hour with us today. I just wanted to start by telling you why I chose this topic. As part of the Addiction Fellowship, all the fellows are assigned a date, and we're told we do this What's New talk once a year. Or there's many editions, but each of us does it once a year. And we were given the freedom of choosing what topic to talk about. And I was thinking about my background in psychiatry and the various medication options we have for a lot of psychiatric conditions. For example, in the treatment of depression with antidepressants, we have a variety of different drug categories of antidepressants to choose from. And even within those drug classes, we have multiple different individual specific drugs to choose from. So we have a lot of different options, and compare that with substance use disorders, where a lot of these substance use disorder treatments we can count on the fingers of one hand. And for some substance use disorders like stimulant use disorder, we don't have any proven medication treatments to treat some substance use disorders. So I think when it comes to new research and development into other formulations for substance use disorders, it's very exciting and very much necessary. So hopefully by the end of this talk, you'll have some understanding of newer formulations for substance use disorders. I want to acknowledge that I'm a guest on the unceded traditional territories of the Coast Salish peoples, and I don't have any financial disclosures. Just an overview of the talk. We'll start by overviewing the benefits of long-acting medications, and then we'll talk more specifically about various long-acting formulations available for specific substance use disorders. So we'll start with the benefits of long-acting medications. I think one of the major benefits to patients is that it helps with convenience. Talk to a lot of patients in psychiatry. Many psychiatry patients are given injectable formulations of long-acting depot antipsychotic medications, and sometimes that's because of adherence issues, and sometimes that's because their lifestyles are so transient that it's difficult for them to adhere to a daily regimen of medication. But for a lot of patients that do have that stability, they actually prefer to have the injectable monthly depots, for example, because it helps them to remember to take the medication compared to having to remember on a daily basis. So I think one patient-centered factor that is beneficial with long-acting medications is the convenience factor. And alongside that is increased adherence to medications compared to daily regimens. I remember being prescribed an antibiotic, and even though it was only for a week-long course, I probably missed about half the doses. And some of that was because I forget, but other times it was because we all have busy schedules, and sometimes the days start blurring together, and we have these false memories that we mistakenly believe we had taken the dose, even though we were thinking about yesterday that we had taken the dose. I think long-acting medications provide clarity about the reasons why there may be poor response. And what I mean by that is sometimes patients come into the clinic and it's not necessarily that they are maliciously lying to the clinician, but either consciously or subconsciously they want to please their clinician. So they'll report that they have been taking the medication as prescribed on a daily basis. And sometimes that will lead the clinician to conclude that a medication isn't effective despite being taken on a regular prescribed basis. And I think sometimes that leads to us giving up on medications a little bit soon, assuming that it's because the medication isn't effective, when in reality it may be because that the medication wasn't taken as prescribed. So I think with long-acting medications, because it's easier to track the dosage and administration of medications, we can know with more certainty whether the poor response is because of non-adherence or because of simple ineffectiveness of the medication. I think it reduces social stigma. I used to work in pharmacy practice in a community pharmacy, busy environment, long lineups of patients, and oftentimes in the pickup window, it's staffed by a pharmacy assistant. And I remember methadone patients coming in for their daily witness would line up in the pharmacy, and then they get to the front of the line and they'd say, "I'm here for my methadone." And then the assistant would yell across the pharmacy, "Methadone patient," and everybody would look around and stop. And I was thinking about that type of situation and how it really stigmatizes the patient. Rather than being called, "Mr. Smith is here for his medications," he's now just the methadone patient who needs special service from the pharmacist. And I think long-acting medications also reduce drug diversion. With daily dispensed medications or daily carry medications, it's easier to take that drug and to misuse it or put it into a different place where it's not intended. With long-acting injectable medications, because we are tracking the administration in the clinic setting, it can reduce the amount of drug diversion that happens. This is just a short list that I thought of. I'm sure there's a lot of other long-acting medication benefits that are out there. And now we'll talk a little bit about opioid use disorder and the long-acting medications available for opioid use disorder. Just a quick word about terminology of opiates versus opioids. For the purposes of this talk and for the purposes of a lot of the settings that we work in, we use these terms interchangeably. But just as a point of clarification, what we mean when we refer to opiates is we're referring to the compounds of the natural opium poppy, namely heroin, morphine, and codeine are felt to be described as opiates. And compared to opioids, which are felt to be synthetic versions made to mimic naturally occurring opiates, they would be things like oxycodone, hydromorphone, and fentanyl. We won't belabor this point much further for this talk, but just know that there is a difference between the term opiates and opioids. How do they work? They mimic endorphins in the body. Endorphins are chemicals that are released by the brain when there is a pain response. Pain, as we know, has many beneficial effects. It tells us when we're in danger, when we need to do something, when we need to act. But at some point, that pain response isn't necessary anymore. We need to act on the pain. We don't need to continuously feel pain. So the body responds to pain by releasing endorphins, which dampen down that pain response to allow us a chance to act. And opioids were initially designed to mimic that effect of the endorphins to dampen down the pain response. The area of the central nervous system, meaning the brain and the spinal cord areas where the pain effect is active, is felt to be mostly in the spinal cord. But opioids have effects on other parts of the central nervous system too. Notably, the important parts are in the brainstem, where opioids can cause the side effects of decreasing the respiratory drive, and that's one of the big problems of overdose. And the other part of the brain that's important to recognize is the limbic system, which is felt to be responsible for the pleasure and reward pathways, which is how opioids develop their euphoric effects and reinforcing effects. This is probably just a summary and review for most of you folks about conventional options for opioid agonist therapy. We have Suboxone, Methadose, and Cadian. All of these are daily medications, either orally or sublingually. Suboxone comes in tablets that come in these little foils that you peel off and then it's dissolved under the tongue. This is a dispense set that measures out the milliliter amount of Methadose, and each dispense set costs a few $100s, just for interest. And then these are Cadian capsules. So they come in these clear capsules, and embedded within each capsule are these individual pellets. And it's recommended for the use of opioid agonist therapy to sprinkle the pellets onto applesauce for ingestion to prevent diversion. We won't talk too much about Methadose and Cadian today, but we'll focus more on the Suboxone opioid agonist therapy. Talking a little bit more about Suboxone, again, some background information, combination of two different medications, buprenorphine and naloxone. Buprenorphine is a partial opioid receptor agonist. So comparing that to other opioids where they're full agonists, rather than turning the light switch on the entire way, it works almost like a light dimmer. Rather than giving the full effect of the opioid, it only gives a part effect. And it's felt that this ceiling effect leads to less overdose potential and increases the safety profile of buprenorphine. The naloxone component was added to discourage misuse. As we all know, naloxone, take-home naloxone kits, marketed as Narcan, is an opioid blocker, so it reverses the action of opioids. However, it's only effective if it's given in injectable formulation, which is why the take-home naloxone kits have to be injected. If it's taken orally or sublingually, as Suboxone is meant to be taken, it doesn't get absorbed into the bloodstream in adequate concentrations to cause a clinical effect. So if it's taken sublingually, as Suboxone is, it doesn't have any clinical effect. It doesn't block the buprenorphine. Usually given daily sublingually, and important thing to know is that it takes about 2 to 10 minutes to fully dissolve underneath the tongue. And if any of the dose is swallowed, then it doesn't confer the full effect. And then usually the dosage range is 8 milligrams up to 32 milligrams, although there are some case reports of doses exceeding those values. So we'll focus a little bit more on buprenorphine specifically when we talk about long-acting opioid agonist therapy options. Right now, there's two main options that are out there. They're marketed as Probufene and Sublocade. Probufene is a subdermal implant. What that means is it gets implanted underneath the skin, and it's meant to last 6 months. Sublocade is given as a subcutaneous injection every 4 weeks, and as you can tell by the name, it's from the same drug company as Suboxone, hence the same prefix of sub. We'll start with Probufene. Comes as these 4 small implantable rods, and it's meant to be implanted into the inner arm, lasting 6 months. This is one of the studies on Probufene which led to its approval for use in opioid use disorder. So it's an article from the Journal of the American Medical Association from 2016. It looked at 177 patients with opioid dependence, and they followed them over a 24-week outpatient period. They were randomized to either receiving buprenorphine implants or traditional sublingual Suboxone. They should say buprenorphine and naloxone sublingual. And the main measure of effect was the number or proportion of responders. And what they defined as response to the medication is at least 4 out of 6 months without opioid use, as per urine drug screen and self-report from the patients. What did they find? They found that in the buprenorphine implant group, about 96% of patients were considered responders. And in the more traditional sublingual buprenorphine group, about 88% of patients were deemed responders. So they concluded that buprenorphine implants were not inferior to more traditional sublingual buprenorphine in terms of response. And they showed that the difference in response rate favoring the buprenorphine implants was 8.8%. And the number needed to treat is just an indication of how many patients would need to be given one intervention as compared to another intervention for one of them to feel extra benefit. And that was a number around 11. So if 11 patients were given implants instead of sublingual buprenorphine, according to this study, one of them would have more response. And you might think about this study and thinking about the high response rate, you might question that, because a lot of our clinical practice, we don't achieve response rates at 90% or greater than 90%. So you might start to wonder about the study itself. And if you look a little bit more closely at the demographics of the study, the patient population they studied, it was somewhat restrictive. So a large proportion of the study patients were Caucasian, many of them were employed, they were on prescription opioids prior to developing opioid use disorder rather than illicit opioids. There was a low prevalence of polysubstance use. And notably, they were stable for 3 months on 8 milligrams or less of sublingual buprenorphine before enrollment in the study. So it points to the level of stability in the patient population that they had selected for to include into the study. and that may not be fully indicative of the types of patients that we typically see in the downtown Vancouver area, where people tend to be on higher doses of sublingual buprenorphine, and they may not necessarily have the same response rate to an implant formulation of buprenorphine like this study population. Regardless, Probuphine was approved by Health Canada in April of 2018. However, the indication is specific to the patients that had been stable for 3 months on 8 milligrams or less of sublingual buprenorphine. So it's somewhat restrictive on the types of patients that would be able to get Probuphine, at least through the indicated route. It costs about $1,500 for each implant, and the implant lasts 6 months, and it can only be repeated 1 time. So according to the product monograph, it can be repeated 1 time in the other arm, and after that, after a 12-month period, it hasn't been studied longer than that, and it's not recommended to use more than 12 months. So at the 12-month mark, you have a difficult decision to make on whether to simply take them off buprenorphine altogether or to transition back to sublingual. And that might defeat the whole purpose of getting somebody onto Probuphine if you end up transitioning back to sublingual after the 12-month mark. So Probuphine has some restrictions. What else is available out there? There's another medication called Sublocade, and that comes as a subcutaneous injection. It has to be given a little bit more frequently, so rather than every 6 months, it's every 4 weeks. And we'll talk a little bit more about Sublocade. It comes in 2 different doses, 100 milligrams and 300 milligrams. The way that it's recommended to initiate Sublocade is to have at least a 7-day period of sublingual buprenorphine between 8 to 24 milligrams daily, and that's mostly to make sure that somebody is able to tolerate buprenorphine before you inject them with the medication, because once you inject it, you can't take it out of their system, as compared to buprenorphine sublingual, where if you give the dose, it will wear off within a few days, or depending on the dose, maybe even a few hours. So then you can gauge tolerability in that sense before giving them that injection. The reason why there's 2 doses is because it's felt that when you first start Sublocade, you want to load the tank up, so to speak. So you give 2 doses of 300 milligrams every 4 weeks, and then you would thereafter indefinitely treat with a 100 milligram dose every 4 weeks. There are some cases where the 100 milligram maintenance dose isn't providing enough effect, in which case you can use the 300 milligram dose, but it's felt that the 300 milligram dose leads to more adverse effects, namely injection site reactions. This was a study from earlier this year in February in the Lancet journal that looked at the efficacy and safety of the Sublocade. It took 504 study patients with moderate or severe opiate use disorder, and again followed over a 24-week outpatient period. They were randomized to 3 different groups. So one group received the Sublocade 300 milligram injection every 28 days for 6 doses. One received 300 milligrams every 28 days for 2 doses, followed by 100 milligrams for 4 doses. And third group received placebo injections of normal saline every 28 days. And the main measure of efficacy was the percentage of patients that were abstinent from weeks 5 to 24 of the study. This is a graph that looks at the study results. So you can see around the 2-week mark, there was a separation between the placebo group and both arms of the buprenorphine subcutaneous injectable group in terms of percentage of response. And if we represent that numerically, about 40% of patients achieved response to the Sublocade groups, as opposed to 5% in the placebo group. So we could see a statistical difference comparing Sublocade and placebo. And again, the reason why Sublocade is dosed as 300 milligrams for 2 doses, followed by 100 milligrams for 4 doses, is because of less injection site and other adverse reactions, even though they have similar effect between the 2 dosing arms. Where are we now with Sublocade? It's been approved by Health Canada recently, a few months ago. However, it's not yet marketed in Canada. And because it's not yet marketed in Canada, we don't have a price point yet for the Canadian market. Although in the United States, I think each dose is about $1,600 warehouse price. So it's rather expensive, at least in the United States market. And even though it's not yet marketed in Canada, it can be accessed through a special program called the Special Access Program, run by Health Canada. And just to talk a little bit about what the Special Access Program is, to give an overview, it's a Health Canada initiative that helps to access drugs that otherwise are not commercially available in Canada. And these are some of the prerequisites. It needs to be a request submitted by a practitioner, and it has to be given to patients when conventional treatments have failed in what they call serious or life-threatening conditions. And this is just to get access to the drug. It doesn't include coverage of the drug. So coverage of the drug is another issue as well, and that would be another discussion either with the health authority that you're working in or through PharmaCare if you're working in, say, an outpatient setting and you want coverage through PharmaCare, or the patient would have to pay himself or herself. So we've talked about long-acting options for opiate agonist therapy. I wanted to also spend a little bit of time talking about long-acting opiate antagonist therapy, and namely that would be naltrexone, also marketed as Vivitrol, which is an intramuscular injection every 4 weeks. And it's an intramuscular injection in the gluteal muscle or the bum muscle. The reason for that is it's a relatively large volume amount. It's about a 4 millimeter syringe. So it's felt that some people with deltoid muscles like mine aren't enough to carry 4 milliliters, so they inject into the bum. So we'll talk a little bit more about Vivitrol, or naltrexone. We'll start with naltrexone. Naltrexone is an opiate antagonist similar to naloxone, but it's described as an oral 24-hour version of naloxone. So it's meant to be given typically once a day at 50 milligrams, but there's some alternative doses of 100 milligrams every 2 days or 150 milligrams every 3 days. Vivitrol is the same compound of naltrexone except put into microspheres. And the thought is that microspheres release the naltrexone slowly over time. So each dose lasts about 4 weeks at 300 milligrams or 380 milligrams. This was a study that compared Vivitrol with traditional sublingual buprenorphine naloxone or Suboxone. From the Lancet journal in 2018, they took 570 patients with opioid use disorder and they followed them again over a 24-week outpatient period. They were randomized to 2 groups, either the Vivitrol injectable arm or the sublingual Suboxone arm. And their main measure for effectiveness was the proportion of patients that stayed relapse-free. And relapse as indicated by either 4 consecutive weeks of urine drug screens positive for opioids or 4 consecutive weeks of opioid use by self-report or 7 consecutive days of self-reported opioid use. And this was one of the table in the results, the intention to treat groups. What does intention to treat mean? It means that they take all the patients that have been randomized from the start of the study and they included them in the analysis. The red line here indicates the survival rate for the Vivitrol group and the blue line indicates the survival rate of the sublingual Suboxone group. And you can see that there was a greater rate of relapse-free survival in the Suboxone group, indicating that Suboxone worked a little bit better than the Vivitrol group in the intention to treat group. The thinking behind this is that a lot of the patients that were initiated on Vivitrol didn't actually complete the induction process. Many of them failed the induction process, which led to them relapsing to opioid use. And it can be argued that it's a little bit harder to initiate somebody on Vivitrol because it is an opioid blocker. So people will typically have to be abstinent from opioids for a period of 7 to 10 days before initiation of Vivitrol. And of course, during that period, there's withdrawal symptoms and other things that can lead to relapse. So the study authors also looked at a per protocol group. And what they did here is they filtered out the individuals that had failed the induction of Vivitrol. And they looked at the patients that successfully completed the induction of Vivitrol and they compared those patients to sublingual buprenorphine. And it showed that they had similar response rates when comparing the per protocol group, meaning the patients that were successfully initiated on Vivitrol. And because of this, what they concluded is that it's more difficult to initiate naltrexone because it needs that preceding period of abstinence from opioids. But for the patients that were able to be initiated on naltrexone, there was similar effectiveness. Where are we now with Vivitrol? The Food and Drug Administration in the United States has approved it for the treatment of both opioid use disorder and alcohol use disorder. However, in Canada, it's not yet approved by Health Canada, but again, similar to Sublocade, it is available through the Special Access Program. This is a summary slide of the long-acting medications for opioid use disorder. We talked about Probuphine and Sublocade being the opiate agonist options and Vivitrol being the opiate antagonist option. And then it just summarizes the status of the Food and Drug Administration approval, Health Canada approval, and the availability. And again, because Sublocade and Vivitrol either isn't yet marketed or approved in Canada, we don't have a pricing point. But Sublocade is about $1,600 warehouse price in the United States, and Vivitrol is about $1,200, I believe, per dose. But of course, the prices may change once it hits Canadian market because they have different competition types of, or they have different competition than the United States and different price points of other medications. Okay, so we talked about opioid use disorder. We'll talk a little bit about alcohol use disorder next. This is just an overview of the medication options for alcohol use disorder as per the American Psychiatric Association. Their guidelines that came out, I think last year, indicates first-line options to be naltrexone and acamprosate for medication treatment of alcohol use disorder. And their second-line recommended options are disulfiram, gabapentin, and topiramate. Of these options, naltrexone, acamprosate, and disulfiram are indicated for alcohol use disorder, and gabapentin and topiramate are being used off-label. That doesn't necessarily mean they're not effective for alcohol use disorder, it just means that they haven't officially been indicated for alcohol use disorder. And we won't go into all 5 of these medications today, but we'll talk about a couple. We'll start with naltrexone, which we have already talked a bit about with the opioid use disorder. Again, opioid receptor antagonist, blocks opioids, felt to be an oral 24-hour version of naloxone. The way it's felt to work in alcohol specifically is it blocks the dopamine rewarding effects in the brain. And through this mechanism, it's felt to decrease the euphoria or the high-inducing effects of alcohol. This was a study back in 2005, actually, a while ago, on Vivitrol's use in alcohol dependence. It took 627 patients with alcohol dependence, and they followed them over a 6-month period. They were randomized to 3 different arms, either naltrexone 380 milligrams intramuscular every 4 weeks, naltrexone 190 milligrams intramuscularly every 4 weeks, or a placebo arm of normal saline injections every 4 weeks. And the main measure of efficacy was the number of heavy drinking days as defined by 4 or more drinks for females or 5 or more drinks for males. And compared to placebo, they found that the group receiving the higher dose of naltrexone had a 25% reduction in heavy drinking days compared to 17% of reduction in heavy drinking days in the 190 milligram group. And because of this difference, naltrexone intramuscular was marketed as 380 milligram dose every 4 weeks. And again, just a reminder that Vivitrol has received FDA approval for opioid use disorder and alcohol use disorder, but not yet available in Canada, but is available through the Special Access Program. Going back to this guide about the American Psychiatric Association guidelines, we'll talk about gabapentin next. Just a background about gabapentin. This is a diagram showing GABA, which is the main inhibitory neurotransmitter in the brain. And gabapentin was made to mimic the effects of GABA, and you can tell that they have similar chemical structures. That was the way gabapentin was designed. And GABA is the main inhibitory neurotransmitter, and glutamate is the main excitatory neurotransmitter in the brain. So the idea is that typically they're in balance in the brain. Alcohol works directly on GABA receptors, so it increases the overall inhibitory effects on the brain. And gabapentin was meant to act the same way. However, gabapentin doesn't work directly on the GABA receptor. It actually binds to another site, the voltage-dependent calcium channels, and when it binds, it slows down the release of the excitatory neurotransmitter glutamate. And essentially, it does the same thing as enhancing GABA by reducing the excitatory glutamate, it increases the balance of GABA compared to glutamate. So essentially it works like a GABA agent, although not directly in the GABA receptors. This is a trial from 2014 that looked at the role of gabapentin in alcohol dependence. This was for oral gabapentin, 3 times daily. So it took 150 patients with alcohol dependence and followed them over a 12-week period. There were 3 arms, 300 milligrams orally 3 times daily, 600 milligrams orally 3 times daily, and a placebo group. And they had 2 main measures of effect: heavy drinking and complete abstinence. This table shows the results of heavy drinking, and there was a difference between both gabapentin arms and placebo, but a bigger effect with the higher dose of gabapentin at 600 milligrams 3 times daily, or 1800 milligrams a day. And similarly with complete abstinence, it also showed a difference between the gabapentin arms and the placebo arm, but a greater effect in the higher dose of gabapentin. So the conclusion is that gabapentin may be effective for the treatment of alcohol dependence, according to this study. In terms of long-acting gabapentin formulations, not as long-acting as, for example, the opioid agonist therapy or opioid antagonist therapy. There's 2 brand name formulations that I want to talk about, and both of these are still given on a daily basis, although the idea is that rather than 3 times daily, they only have to be given either once daily or twice daily. So theoretically, it might still lead to increased adherence and some benefits of a longer acting medication. Marketed as Grelise and Horizont. We'll talk about Grelise at first. Grelise is just the same gabapentin component except put into an extended release formulation. And the way it was designed to be extended release is that the tablets are designed to swallow in stomach acid, and then it gradually releases gabapentin over time. And it's a once daily dose. It's received FDA approval for postherpeutic neuralgia, which is just a fancy term of saying nerve pain that occurs after shingles. Unfortunately, there haven't been any trials that I could find for alcohol use disorder, but maybe there's some role for Grelise. Now we'll focus on Horizont, which is the alternative long-acting gabapentin formulation. Rather than simply being an extended release formulation of gabapentin, it's designed as a prodrug that gets metabolized into gabapentin. Prodrugs typically don't have clinical effect until they're metabolized in the body into the active compound. And the prodrug is called gabapentin enacarbonyl, which is just a salt formulation. And again, it's formulated as a prodrug, but you can see on the right side of the chemical, it has the same chemical structure as gabapentin. And in the body, through water hydrolysis, hydro meaning water, lysis meaning breakage, it gets metabolized into gabapentin. Comparing that to gabapentin immediate release, which is dosed 3 times a day, Horizont is marketed as once or twice a day dosing. This is a study from earlier this year in 2019, January. It took 346 patients with moderate or more severe alcohol use disorder, and they followed them over a 6-month period, and they looked at Horizont and its effect. They randomized individuals to either Horizont at 600 milligrams twice daily or placebo, and the main measure of effect was heavy outcome or heavy drinking days. This is a graphical demonstration of what they found. So they looked at the percentage of subjects with no heavy drinking days, and there was a small increase in the response with Horizont compared to the placebo arm. However, it wasn't significant of a difference compared to placebo, and the authors also noted that there was no clinical benefit for abstinence or craving. So unfortunately, it was a negative study. And because it was a negative study, Horizont has only received FDA approval for postherpeutic neuralgia, again, nerve pain after shingles, and for restless leg syndrome. It's not approved for alcohol use disorder, and because the FDA doesn't approve it, Health Canada usually follows their lead, and it's not available in Canada. A summary of what we talked about for alcohol use disorder medication options: Vivitrol, the intramuscular every 4-week dose of naltrexone, and the Horizont, which unfortunately did not demonstrate effect, so it's not approved by either the FDA or Health Canada. Okay, I just wanted to end by briefly talking about nicotine use disorder. Again, a review for many of us, nicotine use disorder medication options. We have nicotine replacement therapy that comes in various forms, patches, gums, lozenge, inhaler. And prescription options, we have varenicline, marketed as Champix, or bupropion, which is marketed as Zyban. And there's also some talk now about vaping being used as a nicotine use disorder medication option to reduce the use of cigarettes. And theoretically speaking, it can lead to some reduced negative effects of cigarette smoking when used through vaping. There's been talk about a nicotine vaccine. So the idea of the nicotine vaccine is that nicotine enters our body when we smoke, and then it crosses the blood-brain barrier, and once it's in the brain, it creates a clinical effect. The nicotine vaccine is meant to induce the production of antibodies, which will bind to nicotine, and because the compound of the antibody and the nicotine is too large to cross the blood-brain barrier, it reduces the ability of nicotine to exact a brain effect. So that's the theory behind a nicotine vaccine. This is a rat study in 2004, where rats were given a vaccine to nicotine, and it showed that after they were given a vaccine, it reduced their brain nicotine levels despite ongoing nicotine administration. And it also showed that there was a reduction in the nicotine-related motor activity of the rats. So it was early signs that maybe a nicotine vaccine can have effect in reducing the amount of nicotine that crosses into the brain. And then in 2006, they did a subsequent study again in rats that were administered a nicotine vaccine, and it reduced again the brain nicotine levels, and it also reduced the rate that the rats were self-administering nicotine, indicating that they weren't getting the rewarding effects of nicotine anymore after they were administered the vaccine. So these were studies in rats, and naturally you might ask, what about for humans? And in 2012, the Cochrane database of systematic reviews looked at this specific question about nicotine vaccines in the use of smoking cessation, and they found 2 phase 3 trials in humans which showed no statistical difference between individuals who were given the nicotine vaccine and placebo. So their conclusion is that there's no evidence yet for long-term smoking cessation in nicotine vaccines. However, drug companies haven't given up completely. They're still doing some more research into the nicotine vaccine, and there's been talk that maybe it was just that the nicotine vaccine formulations they have used in their research wasn't purified enough. So now they're talking about using the so-called S-enantiomer purified version of the nicotine vaccine, and perhaps if they were able to develop that and study that, it may have some clinical effects that they couldn't find with their previous nicotine vaccines. Just a couple take-home points for this talk. Just wanted to review the benefits of long-acting medications that we started the talk with. Again, greater convenience for patients. It can increase adherence, gives us more clarity about why patients may be poor responders, and again, reduces social stigma and reduces drug diversion. Second take-home point is just to give an overview of the different formulations available for opioid use disorder and alcohol use disorder. Again, propionate and Sublocade are buprenorphine compounds, which are given either 4 weeks or 6 months at a time. And Vivitrol is an opiate antagonist, which is given intramuscular 4 weeks at a time for both opioid use disorder and alcohol use disorder. And just for completeness sake, Horizon's included there, even though there was that negative study demonstrating it isn't more effective than placebo statistically to indicate that it's been approved. Yeah, so we did finish a little bit earlier. I was hoping I would take it to the end of the hour so I could make a buzzer beater like Kawhi Leonard, but we can't all be heroes. Yeah, so we'll just open up to questions. Dr. Elefante?
Hi, Dan. Thank you for the presentation. Just a question about the nicotine vaccine. I know it's like in phase 1 safety trials, were there any indication that might affect people who have psychotic symptoms? Or as you might know, a lot of people with schizophrenia, they could opt to smoke more because wondering the vaccine might affect the population. Was there any signal from phase 1 studies, the safety part of their trial, whether there were some adverse events?
Yeah, so the question is about the nicotine vaccine specifically and whether there's any phase 1 safety trials indicating specifically for patients with psychosis, whether there's an impact on the antipsychotic effect. I didn't look too closely at the phase 1 trials. I only looked at the database, the Cochrane database of the systematic reviews, and essentially, I think the thinking behind that is that smoking can induce the metabolism of some antipsychotic medications. So theoretically, there may be an effect on changing the levels of antipsychotics in the blood if somebody was subjected to a vaccine. But I don't know specifically about phase 1 safety trials, whether there's been found to be an effect in patients with psychosis. Yes.
So I'm a nurse who has chronic pain, and I keep getting mistaken for an addict when I go into emergency and horrible pain. Do you have any advice as a clinician, and then also, like, I think it's become very difficult to access pain medication in the state, I think, because of the fentanyl crisis and lots of factors. Do you have any comments on that?
Mm-hmm. Yeah, a comment and a question. Comment is about the difficulty for patients with chronic pain to access pain treatment services without being labeled as an addict, and the increasing difficulty of accessing, I suppose, opioid-based medications, which can be very effective for pain in this context of the fentanyl and the opioid crisis. I think it's a difficult question to answer. I think we're starting to work towards reducing the stigma associated with the use of opioids. But I think there's still a long way to go in terms of reducing that stigma to allow patients with chronic pain to feel welcome in certain settings when they're only seeking treatment for chronic pain. Yeah, I don't know how much else I can answer that question. Yes.
Okay, regarding the Probufene implants, I thought I heard you say that it wasn't intended for longer than 12 months. And at that point, there would be some plan for discontinuing or transitioning to the oral tablets. Is there a best practices tapering procedure that is used for the long-acting or for any, really, Suboxone?
Yeah, thank you. Questions about Probufene, and Probufene right now being indicated only for 12 months duration, whether there's a tapering process at the end of that 12-month period to transition back to oral sublingual buprenorphine or simple discontinuation. I think the Probufene implants were designed in such a way that they release a certain amount of plasma concentration of buprenorphine over time, and it's meant to last the full 6 months. So I don't think you need to taper the dose of the Probufene over time. I think at the 6-month mark, it's simply removed from the arm in an office-based procedure. And at that point, because there still is theoretically some buprenorphine effect in the system, that they could then be transitioned back to whatever dose of buprenorphine they were on stably before. And again, most of the patients, or at least all the patients, should have only been on buprenorphine 8 milligrams or less. So they would have likely they would likely need that similar amount of a lower dose of buprenorphine after they remove the Probufene.
You would think, but like I'm a person in recovery and I'm actually on Suboxone, and the reports of like withdrawal effects after discontinuing use vary so much. And you'd think that 8 milligrams would be a low dose, but I've actually heard that that's a pretty high dose to jump off of. So there doesn't really seem to be much information about successful tapering methods. And there are a lot of reports of people being in withdrawal for like months, 22 days after continuing use. So yeah, it's just something that I'm curious about.
Mm-hmm. Yeah, so the comment is about the difficulty of transitioning, I guess, between different formulations and the withdrawal effects that might come in the transition period. And it can be a challenge because, again, the they are different formulations, and there may be a lag window between the effect of a sublingual compared to the subdermal implant. I think as of now, there haven't been too many patients that have been given the Probufin for us to really know for certain whether there is an ideal way of transitioning between the sublingual and the subdermal. But I think right now, how the manufacturer suggests it being used is once they're stable for at least 3 months on 8 milligrams or less of the sublingual dose before transitioning to the subdermal implant. Maybe we'll go here.
I just had a question about the Sublocade.
Okay.
I believe that correctional services has been using it, sorry, for their special access program. Did you come across any data on the Sublocade use in correctional services?
The question is about Sublocade and special access for it in correctional settings, and whether I've come across any of the information about its use in correctional settings. I didn't come across any direct information in correctional settings, but I think that's a good point, that in the correctional setting, Sublocade can have significant benefit because there's a risk of diversion in that type of setting with such a restrictive environment. And I think it's a very good point to make that in a correctional setting or other restrictive setting, Sublocade can lead to significant increase in benefit for opioid use disorder.
We didn't come across any actual data that they've been collecting on the use. I think they have been using it since Canadian Correctional Services.
Yeah, the question is about whether I've come across any data that looks at the use of Sublocade in the correctional setting, which seems to have been in process since November of 2018. No, I haven't come across any specific direct data. There's a question.
Quick question. For the study was super narrow with the participants. Are there any studies that are a little bit more relevant to like on the outreach nurse in the downtown east side, like that, like or like indigenous folks, or like is there any other than white people that have jobs? I don't. Yeah, like, I'm just wondering if they're actually trialing for those type of people.
Yeah, the question is about Probufin and the narrow restrictive range of people that may benefit from it, and talking more specifically about the study that looked at employed Caucasian people with low rates of polysubstance use, et cetera. And the question is whether there's been other trials with a more generalizable population. I didn't come across any more generalized trials. There were a few trials of Probufin leading up to the more recent trial that we talked about today. But unfortunately, I don't know if they are trialing it in more varied populations. So right now, unfortunately, we're stuck with that as our landmark study for the use of Probufin. And I agree with you, it's a very restrictive patient population that would be indicated for the use of Probufin. Yes.
Well, that just sparked a second question from me. I'd like to get into, if I may. The one is, all of the outcomes you presented strike me as largely surrogate outcomes. There hopefully aren't a lot of people with alcohol use disorder in this room, but there probably are a substantial number who had at least 4 or 5 drinks in the last month. So that's a surrogate outcome, which isn't necessarily a horrendous outcome. I'm curious, do they report on anything else like functionality, safety, mortality, or no? The second question is maybe for another rounds, but what would be, if the Center for Substance Use does a series of trials in this area, what would be the optimum design for a trial? Because if you did, you wouldn't be limited the way these are. You didn't tell us whether they're sponsored by the manufacturer, but one would guess that they probably are. And the design of the trials you showed us almost certainly came from the company that made the drug. It's a very tough question to answer on the spur of the moment, but it might be a very interesting additional round on what would be the ideal design of trials to figure out whether, for example, the people of BC should be paying these inordinate amounts of money for a treatment.
Yeah, a comment and a question, I guess. A comment about the way that many of the studies presented in this talk looked at surrogate markers of effect rather than other more, I suppose, direct clinical effects like functionality or employability, I suppose. And a secondary question about whether there would be a more optimal way of designing these research studies such that they would avoid that surrogate marker issue. But I think you're right that all these studies were funded by the drug companies that were coming up with these new formulation of medications. And I think it's difficult, as many of you are aware, that it's a lot of the funding comes from drug companies, and there's not a lot of public funding that's available to run studies like these. But I think it is important to look at other outcomes as well other than the surrogate markers, because of course, heavy drinking days or abstinence may not indicate functionality of individuals. I don't know if the studies look directly at those measures. They may have, but I don't know specifically whether they looked directly at them and measured them. But I think if a research was to be designed to avoid that situation, I think that's a good point, that maybe looking at functionality of individuals using a standardized process may be the optimal way to approach a study in the public realm. Yes.
Could you comment on the evidence for the use of probuphine and safety in pregnancy?
The question is about the evidence and safety of probuphine in pregnant patients. I think similar to other buprenorphine compounds, there's not a lot of data on pregnant individuals. I think buprenorphine has been studied in pregnant rats, and it's shown some, I think, early fetal loss in the rat population. But again, we don't know in the human population whether that is the case. But of course, all these opioid agonist therapies are meant to be balanced out with risk and benefit. And if there is increased benefit to using an opioid agonist therapy in the pregnant population, I think there is a role of the medications. Yes.
Just wondering, is there any follow-up on negative side effects of these medications?
Yeah, the question is about follow-up about negative side effects of these medications. For this talk, we didn't talk specifically about the side effects, but there certainly are side effects to these medications, and that's why for some of these medications, they were meant to be dosed at certain ranges. For example, Sublocade, because the 300 milligram 300 milligram dose led to more side effects, it's recommended only to have 2 300 milligram doses followed by 100 milligram doses. And a lot of the side effects are related to injection site reactions because they're all either given as implants or intramuscular or subcutaneous. But yes, there are more side effects compared to placebo in these medications, but not enough to cause them to lose their approval.
We have an online question.
Oh, yeah, just an online question. How do we mitigate trauma analgesia while clients are maintained on Sublocade? Okay, I guess the question is related to long-acting buprenorphine formulations in general, perhaps, how we can treat pain conditions that arise while somebody is already receiving that medication. I think it's similar to trying to override the effects of, say, sublingual buprenorphine when somebody is in a major accident and they have some buprenorphine on board. I think the idea would be to use high affinity opioid medications like hydromorphone to try to counteract the effects of the buprenorphine. And again, with the Sublocade, it does give us more limitations because we can't take it out of the system once it's already injected into the body. So we can try to override it with other higher affinity opioids like hydromorphone or maybe fentanyl. Any other questions? Well, thanks a lot for coming. There's still some food down here, so. There's this question about posting the slides. Should we answer? Should I just type it, I guess?
Yeah, I think they're still online though. Oh, maybe not. 12:55. Yeah, they should still be there. You can just text. It's up to you.
I'll just type it.
It looks like.
I think I sent it. Yeah, thanks for coming, Dr. Sear. Yeah, thanks for coming and not grilling me with questions.
Actually, I didn't know anything about those monitoring government information. So that's super.
Yeah, but it's not that helpful because it's not effective.
Yeah.